Hi, I'm Sundar Jagannath, Professor of Medicine at Mount Sinai Medical Center, New York. I'm here at Paris enjoying the International Myeloma Workshop number 13. This is well attended and a lot of new information has been brought forth in this meeting. And I would like to share some of those information with you. Specifically, I attended just now a session on new drugs. The first speaker was Ken Anderson from Dana-Farber Cancer Institute. He gave an overview of all the different drugs which are currently in play in multiple myeloma. He talked a little bit about the introduction to monoclonal antibody therapy in multiple myeloma. Then he talked a little bit of an introduction for new proteasome inhibitors. Finally, he also gave introduction to the new immunomodulatory molecule, pomalidomide, coming to the bedside. Then he talked about HDAC inhibitors, which are also in the clinical trial at this time. Then he also talked about several new drugs which are likely to come but are in the preclinical stage. And he was quite excited that the portfolio is rather robust, and a lot of new drugs in the preclinical model are likely to be successful in the treatment of multiple myeloma. Part of the reason for the optimism is that the new genomic initiative and better understanding of the molecular biology of myeloma has given us new targets to go after for the treatment of myeloma. The next speaker was Andrew Jakubowiak. He presented about the new proteasome inhibitors. Andrew Jakubowiak is involved in the development of carfilzomib, a new irreversible proteasome inhibitor for the treatment of multiple myeloma. He has combined carfilzomib with lenalidomide and dexamethasone and is treating newly diagnosed multiple myeloma with this combination. He has shown dramatic, very high response rate in excess of 90%, and very high complete remission and very good partial remission with this treatment without the patients having to go through stem cell transplantation. In addition, he showed some of the data on the role of carfilzomib in patients who have recurrent myeloma even after failing lenalidomide and currently Velcade or bortezomib. So patients who have failed both bortezomib and lenalidomide have been treated with carfilzomib effectively in controlling their cancer, mainly partial remission, minor responses, and stable disease, but that was durable, and so it was meaningful for the patient. He talked about a new compound, a Nereus compound, which is more potent, at least in the preclinical model, than carfilzomib and bortezomib, but this drug yet has to move forward in the clinical development. He also talked about oral proteasome inhibitor, one of the drugs that has come to the clinical trial and is going through phase 1 and phase 2 clinical trial is from Millennium Company. This Millennium compound is a oral proteasome inhibitor similar to Velcade with the same target. So we are all excited that we are able to give this drug. This is given as a drug which is a prodrug, and after absorption it becomes active like bortezomib, and therefore it is able to kill the myeloma cells. So this is very exciting news. There is also oral proteasome inhibitor from carfilzomib, similar to carfilzomib from the Onyx company, but this is somewhat in an earlier phase of development. So this is the excitement in the oral proteasome inhibitors presented by Andrew Jakubowiak. The next presentation was from Martha Lacey. She gave an excellent overview on the new drug pomalidomide. What was exciting about the pomalidomide in a presentation was pomalidomide was effective in patients who has already been exposed to thalidomide and lenalidomide, and the disease was actually growing on lenalidomide. Even in those patients, when you introduced pomalidomide, these patients responded and the response was durable. And of course, it was also effective for patients who had failed both immunomodulatory molecule thalidomide and lenalidomide, as well as bortezomib or Velcade. So this is a very promising drug, very active. And what was interesting about this compound is it was active at 2 milligram, and it could be given continuously, and it was well tolerated. And Paul Richardson has done a dose escalation study and defined 4 milligram as the optimum dose given for 3 weeks on and 1 week off. The French investigators actually gave 4 milligram daily without even a week's break, and it was still well tolerated. Then Martha Lacey laid out the possible side effects of pomalidomide, and what was remarkable was it was better than lenalidomide in the sense it was not that neutropenic or thrombocytopenic, so it was less myelosuppressive than lenalidomide. And unlike thalidomide, the peripheral neuropathy was less intense than with thalidomide. So it did have neuropathy like thalidomide, but it was less so. It did have myelosuppressive effect or low blood counts like lenalidomide, but it was less so. So that's why it has the benefit of both drugs, while the side effects were minimized, and most important, it was still effective even after the patient had failed thalidomide and lenalidomide. So this was very exciting. The next speaker was Dr. Osio. He gave an excellent overview on the development of histone deacetylase inhibitors. Two drugs, simply put, vorinostat and panabinostat. These two drugs act by modifying the DNA, and these drugs synergize very well with Velcade and lenalidomide. So he initially showed that when these drugs were given by themselves, they were not very active. But he said, wait a minute, just because they were not active by themselves doesn't mean these drugs are not effective. He went on to show that when it was combined with Velcade, that it was much more effective, and moreover, patients who were already refractory to Velcade, when you gave panabinostat or vorinostat in combination with Velcade, these patients responded, showing that these new histone deacetylase drugs are able to overcome the drug resistance in the myeloma cells, so that the drugs which were previously resistant now become much more active. And he said that there is large international phase 3 trials has been completed, one from the Novartis company using panabinostat with Velcade and dexamethasone, and another study from Merck using vorinostat with Velcade. And so these results should be made available by the end of the year, probably as a late-breaking news in this upcoming ASH meeting in December 2011. There were, more importantly, additional new drugs are being developed, and this was actually noted by Dr. Anderson, who showed that we can have now selective histone deacetylase inhibitor, which will block only the pathway which was critical in myeloma cells without buying into the side effects of thrombocytopenia and other side effects. So hopefully this is also very promising lead for the treatment of myeloma patients. I had the pleasure of summarizing the state of the art of treatment using monoclonal antibody in multiple myeloma. For quite a long time, the lymphoma patients have benefited from the use of a monoclonal antibody called Rituxan. It's quite effective. They achieve higher complete response rate when used with chemotherapy and longer duration of remission, and this drug is extremely well tolerated with no side effect. So this has now become the standard of care for lymphoma. Unfortunately, there is no drug yet approved for the treatment of multiple myeloma. However, this is a very exciting time. There has been new developments in the technology, new understanding in myeloma, new targets have been identified, and a number of monoclonal antibodies are now coming into the clinical trial. I gave some examples of few which are very promising and which have already reached the phase 3 drug approval stage. One of this drug is an antibody against an antigen called CS1. This monoclonal antibody has a name. It is called elotuzumab. It's an IgG antibody. This particular antibody targets myeloma cells and plasma cells because only plasma cells and myeloma cells have this antigen on the surface. So when you give this antibody, they home to the targets. So this is what we call as targeted therapy. And once the antibody attaches to the cancer cell, then they recruit the surrounding immune cells and complement in order to destroy the myeloma cells. So the mechanism is independent of drug. So even if the cancer cells could be resistant to chemotherapy drug, this antibody may be still able to eliminate the cancer cell. So when this drug was given by itself, when the antibody was given by itself for relapsed myeloma, the activity was only very modest, some stabilization of disease. But we all know lenalidomide, which is an immunomodulatory drug, boosts the immune system in myeloma patient. And so when you give lenalidomide with this drug, elotuzumab, we noted that the response rate are tremendously improved, and also the duration of control of cancer is prolonged. So now this drug has moved on to phase 3 clinical trial, lenalidomide and dexamethasone with or without elotuzumab. Now what about the safety? The drug is extremely safe because, as I said, the monoclonal antibody is a targeted therapy. So the only question is whether there will be infusion reaction, allergic reaction to giving the monoclonal antibody. These days, the monoclonal antibodies are all engineered to become humanized, so they resemble human monoclonal antibody as much as possible or slightly chimeric. So under those circumstances, the infusion reactions are minimal, and also you can give medication like Benadryl and hydrocortisone or steroid to make sure there is very minimal infusion reaction. So it is well tolerated. So we are all very excited to hope this drug gets approved for the treatment of myeloma. The next drug which is interesting is an antibody against IL-6. So interleukin-6 is a growth factor which supports the myeloma cell growth. It feeds the myeloma cell growth. So the IL-6 is produced by the nurse cells or the stromal cells in the bone marrow, and they nurture the myeloma cells and make them drug resistant. By giving this monoclonal antibody, you remove all the floating IL-6 from the milieu so that now the myeloma cells are starved to death, and now you come around with any other chemotherapy, they should die very quickly. So this drug was done in clinical trial, phase 1, phase 2. Again, the drug is extremely well tolerated, no side effect additional because of this drug, maybe a slight leukopenia or a mild anemia, but it's well tolerated. It could be combined with dexamethasone safely, it could be combined with bortezomib safely, but by itself, its activity is only modest. So now this is going on for a phase 3 clinical trial. We know for patients over the age of 65, the VISTA trial established melphalan-prednisone Velcade is the standard of care. So they're going to do a phase 3 clinical trial with melphalan-prednisone and Velcade with or without siltuximab. That's the name of the anti-IL-6 monoclonal antibody. So this is a siltuximab added in this milieu. This is a fully humanized antibody, so the infusion reactions are very minimal. And finally, I also discussed about another new antibody and its mechanism. Now, we know that in myeloma cells, the tumor escapes the immune surveillance, that the patient's own immunity, natural killer cell, is not able to keep the cancer under control. But patients do have immunity and they do have natural killer cells in the body. And if we can boost their efficacy, then we may be able to keep the myeloma under control or even eliminate myeloma. So there is a new monoclonal antibody called anti-KIR monoclonal antibody. Again, a humanized monoclonal antibody, so there is no infusion reaction, it is well tolerated. So what this one will do is actually stimulate the NK cell to kill the myeloma cells. The way the cancer cell escapes the immune surveillance is they, on the one side, They do identify that they are cancer cells, so the NK cells are able to recognize them, but at the other time, the tumor cells will shake hands with them and tell, hey, I am self, because they show HLA-C, they show the same tissue type, so don't kill me, thereby they escape it. Now this monoclonal antibody specifically blocks this handshake and tells, look, this is a cancer cell, get rid of him, and does not allow the cancer cell to say that they are self, and thereby the activated NK cell can now eliminate the cancer cell. And that is a very novel concept, very exciting, and this kind of an approach could be used even in the little bit earlier stage, so-called asymptomatic myeloma, so this is also very exciting. So the future of monoclonal antibody therapy in myeloma is very robust, and I think the patient should volunteer for monoclonal antibody clinical research, because most of them have become highly sophisticated, humanized or fully human antibody with very minimal side effects by taking the medication, and they are really truly targeted therapy, they home to the target.